Wonderful, thank you. Hello and welcome to the Health and Government Operations Committee. A note on witness timing. In this committee, the sponsor of the bill gets 5 minutes to testify, and then we have 2 minutes each for a panel of 5 supporters and 5 in opposition to the bill if we have that many. So 5 witnesses on each side, and the sponsor can designate their extra time to one of the members of their panel should they choose to do so. We ask that people who are testifying conclude their testimony when the timer finishes. Members must be present with their video on during committee, and I remind members that we have 1 question for 1 witness, and the question should, of course, be shorter than the answer. If you have follow-up questions, you can follow up offline with the witnesses. Please use your raise hand function if you have a question, and I will call on you. A reminder that this committee takes a break at about 3:30 for half an hour. So we'll call a break time at an opportune time when we're done with a bill hearing close to 3:30. We only have 6 bills today. The bill order is House Bill 910, followed by 1006, House Bill 1034, House Bill 915, House Bill 919, and finally House Bill 970. So with that, we will hear the first bill, which is Delegate Lisanti, House Bill 910, Health Insurance Hearing Aids for Adults Coverage, and I believe this hearing is being closed captioned.
It is.
Delegate Lisanti.
Thank you, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. The ability to hear is often taken for granted by most of us. Some members of our community, hearing loss propels them into a segregated world of isolation. The inability to afford hearing aids commits these adults to a life filled with obstacles and often barriers to everyday life. COVID-19 brought this issue to the forefront of my consciousness. During the state of emergency, all of us watched the briefings from federal, state, and local officials accompanied by individuals performing sign language. This visual form of communication provoked my thoughts about the issue of hearing aids and accessibility and affordability. During last year's lockdown, many of us stayed in touch with family, friends, and others through the use of technology to overcome loneliness and to maintain human connections. Can you imagine how difficult it was for individuals in our communities without access to hearing aids? Today, you will hear testimony from some of those Marylanders. The ability to help them remains with this committee. As you listen to their stories, I ask you to consider, if you were hearing impaired, how effective could you be in this legislative session if you were unable to afford hearing aids? House Bill 910 is simple. It provides a minimal healthcare benefit of $750 per hearing aid to provide to those individual healthcare providers who do not already provide this healthcare benefit. Current law allows insurance companies who do provide a benefit to establish a cap and a renewal period. And this bill does not speak to that current cap or renewal period. I believe this bill is important for many Marylanders. Therefore, I respectfully request a favorable opinion on this House Bill 910. Thank you, Madam Chair.
Thank you, Delegate Lisanti. Let's hear from Les Greenberg.
Les, you need to unmute.
I'm sorry. Can we start over? My apology. Hi, good afternoon. My name is Les Greenberg. I live at 11600 Tippett Road in Clinton, Maryland. I'm a person with a profound hearing loss. Very fortunately, I have hearing aids that help me deal with that loss and keep me a productive citizen. I'm a member of the Hearing Loss Association of America, HLAA, Prince George's County chapter. Also, I am an NCHAT trainer. That stands for the Network of Consumer Hearing Technology Trainers, a joint program of Gallaudet University and HLAA. After 9 months of training, I go around the area giving presentations about hearing loss and hearing aids. A note, I'm among the very fortunate, as the last part of my career was in the federal government, where the insurance I purchased covered hearing aids. Most Marylanders are not that fortunate today. From others today and in written testimony, I'm sure that you'll hear about statistics that insurance covers other durable medical items but not hearing aids, and about monetary costs. But it's the human cost that concerns me. During the presentations I give, I hear some heart-wrenching stories about spouses, parents, and the storytellers themselves who would be helped by hearing aids but do not have them due to the cost. Even about some folks who have stopped working because of hearing issues. That's the loss of a productive person to the state of Maryland and to the country. One instance I'm thinking about is of a retired gentleman who volunteered to help a local candidate during an election. Henry was well connected and would have made a great aide. However, he had a profound hearing loss. His health insurance did not cover hearing aids, and he had no money for them. After a while, I learned that he had been asked to step back due to a number of miscommunications. Again, a loss of a productive person. By the way, he did get some hearing aids a year later and is back in the saddle. 2 minutes is not a long time to speak to you, so a quick story about myself. When I got my hearing aids, the doctor started to give them to me, but then started to hand them to my wife. He said, "I'm sure him having these will mean a lot to you." I wonder if some of you know someone who, if they had hearing aids, it would make their life, and possibly even yours, better, happier. For all Marylanders, please say yes to Bill 910. Thank you, Madam Chair and members.
Thank you, Mr. Greenberg. Let's hear next from Jane Bellmeyer.
Jane, you need to unmute yourself.
Okay, let's try that again. Ladies and gentlemen of the Health and Government Operations Committee, my name is Jane Bellmeyer. I've been a Maryland resident all of my 61 years and a tax-paying, fully employed person since September 1979, when I landed my first job in radio at WSER in Elkton, Maryland. That was not long after graduating from the broadcasting program at Harvard Community College. However, 6 months earlier, I had been fitted with my first hearing aid. I was 19 and my parents paid for that behind-the-ear device and the ear mold. But 9 years later, a hearing test revealed I would need one in my right ear as well. By this time I was married, my husband and I bought that one. I do not recall the price. 6 years later, I had to get newer, stronger hearing aids because my loss had increased to 85% in each ear. Thankfully, my aunt tipped me off to the Division of Rehabilitative Services. Since I had 2 children to factor into my income, I qualified for assistance. It was the same story in 2006. I was a single mother by then with 2 kids, and I qualified for assistance to cover the $5,400 cost of 2 aids, 2 ear molds, and testing and fitting. However, in 2018, I needed another set. My hearing was changing yet again. This time, one child was married, the others living with friends out of my household. I had to pay every cent of the $4,000 for the hearing aids and $300 for the ear molds. My insurance paid for most of the testing, just the testing. Fortunately, my audiologist knew of an interest-free financing program that broke the cost of monthly payments. And thanks to that $1,200 stimulus check last year, I paid off the remaining $875 and dispatched the debt. There are 1.3 million people in Maryland identified as deaf or hearing impaired. Like me, many are tax-paying, working, voting adults whose health insurance ignores, no, discriminates against us by refusing to pay for our hearing aids. How am I to work if I can't hear? How am I to function if I can't hear when the technology is available? Today, I'm still working in the media, in the newspaper, and I need to be able to hear. These devices are recognized as durable medical equipment, as are the batteries, which means its purchase is tax exempt. Any device recognized as medical equipment should be covered under one's health insurance. Unlike vision insurance, which allows a new set of eyeglasses every other year, most hearing aids are preset and programmable to last more than 2 years because the audio can be boosted internally to meet the wearer's needs. This means the aids need not be replaced as often. I beg you to consider making health insurance policies in force in Maryland cover some percentage of the cost of hearing aids for adults. I beg you to support House Bill 910. Thank you.
Thank you, Ms. Bellmeyer. We do have one person signed up to testify favorable with amendments, so I'm going to take that and then we'll take questions for the whole panel. Candace Robinson.
Good afternoon, Madam Chair, Committee. My name is Dr. Candace Robinson. I am the Executive Director of the Maryland Board of Examiners for Audiologists, Hearing Aid Dispensers, and Speech Language Pathologists. I am also a Doctor of Audiology myself. Our board supports the premise of HB 910, which aims to increase access to amplification for consumers in Maryland, regardless of their private and or managed care organizational health insurance carrier. It addresses this that by proposing a benefit of $750 per ear every 36 months for all adults with hearing loss. The board believes that the basic level of technology, which would be provided for the $750 a month, would not, for $750 per ear every 36 months, would not allow the consumer to take advantage of the benefits provided by current technology, which is more advanced in the ability to help understand in the presence of background noise, localization of sound, and the ability to stream phone calls, television, and meetings to hearing devices. So it wouldn't address all the communication environments. There's also safety provided by a higher level of technology, which helps patients to know where sounds are coming from. The additional expense that would result in an undesirable financial burden for many Marylanders if they were to try to take advantage of that technology. And the board feels that the same should be required as is for children, which is currently $1,400 per year every 36 months, so that it could best address the communication and balance needs of the adult consumers of Maryland. Accordingly, although the board supports the goal of HB 910, the board respectfully requests to make the amendment to change from $750 per year every 36 months to $1,400 every 36 months. Thank you very much.
Thank you. Do we have questions from the members of the committee for the proponents of this bill? I'll give you a second to raise your hands. It looks like we have a question from Delegate Johnson.
Thank you, Madam Chair. Whoever's best on the panel to answer this question, what's the average that you have to change out your hearing aids or hearing devices? The average time.
So I would be happy to answer that question, Delegate Johnson. Typically, as Ms. Bellmeyer said, the average time is typically every 5 years. If you have the advanced technology where you can make the changes, you have enough of a range for changes in gain due to decreases in hearing loss, you have enough features due to changes in jobs and demands of the job for communication, then a higher amount would last for a longer period of time. And that would be more reasonable in our opinion.
All right, thank you. Thank you, Madam Chair.
Absolutely. Any further questions from members of the committee? I'm not seeing any more hands up. Since the only opposition to this bill came in written form, that concludes the hearing on House Bill 910, and we will move to the next bill.
Thank you all very much.
Thank you very much. House Bill 1006, Delegate Crosby, Health Occupations, Service Members, Veterans and Military Spouses, Temporary Licensure, Certification, and Registration. Delegate Crosby. Do we have Delegate Crosby in the room yet?
Yes, he's in the room. I think his audio is connecting.
Excellent. It looks like he might need to log back out and log in again. I see he's struggling, so let's give him a minute.
Delegate Crosby, can you hear us?
Yes, I think I finally got connected. I don't know why my computer wouldn't connect the audio. I apologize. I'm up.
Excellent. Let's hear your bill introduction to House Bill 1006.
Thank you, Madam Chair, Madam Vice Chair, honorable members of the committee. For the record, Delegate Brian Crosby here to present House Bill 1006, entitled Health Occupations, Service Members, Veterans, Military Spouses, Temporary Licensure, Certification, and Registration. Last year, the Maryland General Assembly unanimously passed House Bill 349, which provided reciprocity to service members, veterans, and military spouses for professional license overseen by the Department of Labor, so long as the applicant maintained the corresponding license from another state in good standing. Every year, it seems like we bring one of these bills forward to deal with the onesies and twosies. Instead of taking that approach, we're trying to tackle every license that falls under an entire administration. And House Bill 1006 would extend reciprocity to professionals overseen by the health department for spouses of military service members. So I think instead of reading my testimony, the best thing I can do is give you an example. If you had a service member who was married and was stationed in China Lake, California, and they got reassigned to Fort Meade or reassigned to Pax River, their spouse would then come with them. And if they were a nurse, what happens typically is that they move here, and for 6 months to a year, they wait to go through a licensing process to get recertified, retested in every state they are PCS to. And I can tell you of many of my friends who are in the service and their spouses are nurses, a lot of times they hold nursing certifications in 4, 5, 6 states. On top of that, they're out of work for the first 6 months to a year every time their spouse or service member spouse has a change of station. And that happens in the military for a service member every 3 to 5 years. So, you know, it is this type of language or bill essentially just makes it easier and streamlines the process for our military spousal community. In addition to the language from last year's bill, we worked with anybody who opposed. I think there are a few that are unfavorable, and then several favorable with amendments. I've accepted every amendment to the bill that everybody has proposed. One was permits, because some professions such as morticians use that terminology rather than license or certification. We did put the background check into the bill, so that has to be passed within 1 year of the application date. And then we just defined what the proof of identity to ensure the uniformity between the licensing board for proof of an applicant's status, whether that's a DD-214, a PCS, or a common access card. PCS orders or a common access card. And as so many of you know, Maryland is currently home to about 400,000 veterans, 29,000 active duty members of the armed services, and 19,000 military spouses. And I believe that we should make it easier for the lives of our military families to be easier, and I request a favorable report from the committee, and I'm happy to take questions at this time.
Thank you, Delegate Crosby. Do we have questions from the committee for the sponsor of the bill? I'll give you a second to raise your hands if you have any questions. Delegate Hill.
Oh, all right. Thank you. Thank you, Delegate Crosby, for bringing this bill. 2 parts. Does this apply whether the nurse is working within a military facility or if they're working privately? And why does the nursing compact not manage this issue for them? The interstate compact.
So to the second point, I'm not sure why the nursing compact doesn't manage that. And you know, to be honest, I probably need to familiarize myself with what they specifically cover. To the first point, it would only apply to hospitals that require a Maryland license. So if it is a military hospital on a military post, it would not apply in that regard. And as far as I'm aware, if I have a license from, say, Virginia, and I wanted to work on a military hospital here in Maryland, I could do that already.
All right, thank you.
Thank you. Delegate Belcastro.
Thank you, Madam Chair. And I saw Lynn Nash was raising her hand. It looks like she might have some insight into that question. I was wondering if she could fill us in with what she was going to say.
Yeah, we're going to hear testimony from both Lynn Nash and Christopher Arnold. They're signed up favorable with amendments, so we'll hear from them as soon as we're done with questions for the sponsor. So hopefully she can fold that into her testimony. And if not, we'll ask her the question at that time. Thank you.
Thank you.
Do we have any more questions for the sponsor before we move on to the favorable with amendments panel? I don't see any more. So let's hear next from Lynn Nash.
Thank you so much. Good afternoon, Madam Chair, Madam Vice Chair, and members of the Health and Government Operations Committee. My name is Lynn Nash. I live in District 17, and I'm a nurse. Thank you, Delegate Crosby, for introducing the bill, which allows a service member, a veteran, or a spouse to be able to get an expedited license. It's really an important thing. Maryland currently regulates 20 health occupation categories, one of which is nursing. I'm a retired captain. I have 30 years of service in both the Army and the United States Public Health Service, and I retired in late 2017. I'm also a PhD prepared nurse who currently serves on a number of boards and in other volunteer capacities. You see me today in uniform. I'm a volunteer vaccinator with Maryland Responds, the Medical Reserve Corps, where I have personally given over 1,500 COVID vaccines. I'm only able to vaccinate right now because Governor Hogan used his emergency powers as part of the declaration, expanding the scopes of practice for healthcare providers. So now we have EMTs giving shots, and then allowed practitioners from other states to help. I was born and raised in Vermont. I completed my training in New Hampshire. I returned home, took my boards, and was licensed in Vermont. That was many moons ago, but I currently hold a valid nursing license. When I was a federal nurse, my Vermont license was recognized. If I chose to work outside of a federal agency, however, I had to be licensed in that state. To practice in Maryland, where there is currently a significant shortage, both in nurses and nursing faculty, which could be me, I would have to go through a very onerous and frankly expensive process of getting another license here in Maryland. You see, Maryland is a compact state. Vermont is not. So there are 31 states that accept each other's license, and then there are the others. To get
Ms. Nash,
yes.
Ms. Nash, I just want to note that while your timer's up, Delegate Crosby had 2 minutes left on his, so please feel free to answer.
Thank you. Nursing registration requires a passport, an application, a fingerprint card, and an application for a criminal record check, as well as $140. It's expensive. If a service member meets the requirements, then they get a credential within 15 days of application. That temporary license is only valid for 90 days. So my ask was to change the term military spouse, because as you know, I'm a public health officer, and the military are the Army, Navy, Marines, and Air Force, as well as now the Space Force, but you're forgetting the spouses of the Coast Guard, NOAA, and Public Health. So in 1984, you amended Maryland Code to include Public Health and NOAA in the definition of veterans. However, it would not apply in this bill as it's currently written. So I ask you to amend the language from military to uniformed services. And as the communications director for the Maryland Military Coalition, which represents 17 organizations, 150,000 military connected people in Maryland, I ask you for your support and a favorable report with amendments. Thank you.
Thank you very much, Ms. Nash. We'll move on to Christopher Arnold, and then we'll have questions for this panel. Mr. Arnold.
Hello, everyone. My 9th or 10th appearance with the Health and Government Operations Committee this week. Just kidding, but great to see you all again. I'll address the question first, and then I'll do my testimony. Compacts are tailored to a given profession, while recognition laws attempt to account for all professions regulated by a state. Such laws allow licensed out-of-state professionals to practice within a given state, but they do not affect in-state professionals' ability to practice in person or via telehealth in other states, and thus do not enable continuity of care in most client-provider relationships. An advantage of recognition laws like this one is that they can be enacted in a single legislative session. However, they do not provide for the same near instant licensure verification as interstate compacts, and they lack the enhanced public protection capability of a compacts data system. Thus, we advocate for both approaches simultaneously. The two mechanisms need not be mutually exclusive. Interstate licensure compacts can coexist with universal licensure recognition laws as part of states' broader occupational licensing strategy, as long as the universal laws include an exception for compacts, which in this case it does. So there are two approaches to alleviating barriers to license portability, namely mutual recognition, such as the compacts, and expedited licensure, such as this bill. House Bill 1006 echoes last year's historic military spouse legislation from Speaker Jones that applied to professions regulated by the Division of Occupational and Professional Licensing, and makes identical changes for occupations and professions governed by the health professional licensing boards. From 2011 to 2016, states passed legislation requested by DoD to address the issue of military spouse licensure. For instance, in 2013, Maryland passed chapters 154 and 155 regarding service member licensure and credit for military training and education, as well as expediting military spouse license applications. Since that time, the department has asked states to enhance their spouse licensing processes. In 2019, Maryland passed Chapter 312, requiring the expedited license be issued within 60 days and posting of that timeline on agency websites. This was followed by the Speaker's bill last year, which eliminated the requirements for agencies to determine whether a license was substantially equivalent. However, those changes were limited to the occupations and professions governed by DLLR. Therefore, the health occupations are out of step with what the department considers to be best practices for spouse and service member license reciprocity. Since 2019, the department has encouraged states to engage in immediate actions to fully implement military spouse licensure laws. In the letter to Governor Hogan sent by the SecDef in 2020, we indicated that current law requires boards to evaluate the substantial equivalency of the applicant's application prior to issuing the temporary license, which likely requires the verifying of documentation for review. Limiting this requirement to the issuance of a permanent license or stipulating that the boards perform their initial due diligence using an application and affidavit would limit the time and effort required of the military spouse applicant. The amended version of House Bill 1006 will achieve this parallel full implementation of spouse licensure law for the health occupations, addressing delay reduction and limiting the time boards take to adjudicate applications, and hassle reduction, alleviating requirements for having to provide documentation, utilizing the DoD recognized best practices, and issuing the temporary license that allows the spouse to work immediately. What was done in 2013 was beneficial, but it is time for Maryland to move forward and further enhance its licensing practices for spouses in the health occupations. We appreciate the opportunity to report the policies reflected in the amended version of House Bill 1006, and are especially grateful to the Speaker for last year's efforts, as well as to Delegate Crosby for this bill and his service to our country. Thank you so much.
Thank you very much. We have a question from Delegate Kerr, and any other members, please raise your hand if you have questions for this panel. Delegate Kerr.
Thank you, Madam Chairman. My question's for Lynn Nash. You had mentioned in your testimony that you have a PhD, but that alone is not sufficient for you to teach in a nursing program here in Maryland at one of the nursing schools. Would this bill correct that, or is that something that would have to be addressed at the nursing school accreditation body?
So the issue is, in order to teach, you have to be licensed in the state. Generally, you're required to supervise students out in clinical positions, so you must be licensed there. And I'm currently not licensed in Maryland. So the bill actually would correct, or at least allow an expedited license to be able to do that. But it's just sad that you have to go through, I mean, I've had a license since 1976, to have to go through this rather lengthy process to be able to practice.
Okay, thank you.
Thank you. We have Delegate Hill, followed by Delegate Cullison. Delegate Hill.
Thank you, Madam Chair. Mr. Arnold, can you help me to understand, so are the issues here that because we're talking about the safety of people in Maryland, are we saying that because these people are military spouses, that we should not be concerned that they require the same scrutiny of other people who are transferring their licenses? Or what is I understand that sometimes spouses, the transfer comes quickly and there's not a lot of lead time, so there may be a delay, but why is this group different from anyone else who wants to practice in the state? Why should they get expedited licenses, but other people shouldn't?
Sure. So, a couple of things to unpack in there, but in most instances, military spouses are better trained or more experienced than their civilian counterparts merely by virtue of having to relocate every 2 to 3 years. So when one has, completed the requirements for licensure in 5 or 6 states, by the time that they move, we've found that limiting that, determination by boards to the issuance of a permanent license can get the person working much more quickly. So if it takes, let's say, 9 to 18 months to evaluate your application and your duration in the state is only 24 months, a family that's relying on 2 incomes can't have a person sitting unemployed for 3/4 of the time. So that's why, as a baseline, the department wants to see that license, issued within 30 days, or at least a temporary license while they're undergoing that substantial equivalency determination for the issuance of a permanent license. And as the service secretaries have indicated, spouse licensure is a factor that's used in basing decisions and mission alternatives.
Madam Chair, may I ask a follow-up? I guess not.
One quick follow-up.
All right, thank you. So I understand why why it's important for the families to get someone working quickly. I'm not clear how the fact that they're military gives us an assurance that they don't need the same scrutiny of any other person because they have a civilian license. Their training wasn't different and they're not in military hospitals from what we heard from the sponsor.
Roger. So in terms of a consumer protection, argument, I think the military spouses represent the canary in the coal mine, if you will, and demonstrate the importance of license portability in maintaining a career in any occupation. So that's why we advocate for multiple avenues to license reciprocity, such as immediate actions, near-term actions, and long-term actions. So while the optimal end state, if you will, is the licensing compact, and some of the discussion of qualifications is brought about by getting that compact license. In terms of the state-specific license, an avenue to ease licensure for any applicant is the expedited application and the temporary license approach, while making that substantial equivalency determination for the issuance of a permanent license.
Thank you. Thank you, Madam Chair.
Thank you, Delegate Hill. Delegate Cullison.
Thank you, Madam Chair. This question is for Ms. Nash. I know that we have, I was looking at some letters from a couple of the boards, and they're saying that we have an expedited process. So I guess I'm wondering, and if I'm asking you to repeat yourself, I apologize, but what is our process not really expedited, number one? And number two, my understanding is that in that 6-month period, the person would be given the opportunity to get the qualifications they need to meet whatever standards they're not meeting. Is that correct, or am I reading that incorrectly?
You are reading it correctly. So for example, I have a Vermont license. They would go back and look at my entire education to see whether or not it matches what the Maryland requirements are. But then it's the background check, the fingerprint check, and everything else. If you wanted to know today whether I had a valid license and whether or not I had any claims against my license, you could go to the Vermont website and look and see whether or not I was active and whether or not there were any issues with my level of practice. That would be immediately available to you. So it's just the amount of paperwork, and as Mr. Arnold said, I mean, we move very, very quickly. And if I had a license in every state where I ever practiced, I'd have them on an arm's length worth of licenses. I just think it's really important that we recognize that these folks do come in, they work hard, and they leave. We should offer them an opportunity to do it. My issue, though, is if you attach it only to military spouses, public health service, NOAA, Coast Guard spouses don't fall under that definition right now.
I appreciate that. May I ask one really quick follow-up? Do you, Ms. Nash,
One quick follow-up. Yeah.
I thought I was going to get it in there. Do you continue to pay a licensing fee in Vermont to obtain your Vermont license? Okay.
Yes, ma'am. I just renewed my license and it was $130.
Okay.
And
Thank
it's
you.
good for 2 years.
Thank you very much. Thank you, Madam Chair, for your indulgence.
Absolutely. Let's hear from Delegate Saab.
Thank you, Madam Chairman. My question is this a blanket health occupation? Does that cover almost every health occupancy in the entire state, such as like dental board, nursing board, NPs, PAs, or is it just specific to certain profession, nursing?
I can take that if you'd like. So Delegate Saab, it does anything that the Department of Health manages or any license that the Department of Health manages, this would fall underneath, or this bill would cover.
Okay. Thank you. Thank you, Madam Chairman.
Thank you. I don't see any more questions from members of the committee. I'm giving you one more second to raise your hands. With no further questions, that concludes the hearing on House Bill 1006. And we will move on to the next bill, which is Delegate Collison's bill, House Bill 1034, Prescription Drug Affordability Board Plan of Action, repeal of date for submission. And Delegate Cullison is our only oral panelist. Delegate Cullison.
Thank you, Madam Chair. And this is likely to be the fastest hearing on record. This is one of those cases where COVID ate my homework. And as you know, I'm a huge fan and advocate of the Prescription Drug Affordability Board. And we have set some limits, and we were very ambitious about when they would be able to report to us on their findings about the pharmaceutical system and affordability issues. And we had expected them to have something for us this summer in July of 2021. They're not able to accomplish that goal. So we're taking that date out of the statute. And but in the meantime, the board has promised us that they will have something to us to review before the next session in 2022. So with that, I would ask for a favorable report on House Bill 1034. Thank you.
Thank you, Delegate Cullison. Do we have any questions for Delegate Cullison on this bill? While I give you a second to raise your hands, I will remind the delegate that COVID has eaten the homework of many of us this interim, so you are not alone. I don't see any questions for Delegate Cullison, so that concludes the hearing on House Bill 1034. We are going to move on to House Bill 915, which is Delegate Ampre's bill. Welcome to HGO Committee. This is the work group on Black, Latino, and other underrepresented mental health professionals. Delegate Ampre, would you like to introduce your bill? I see maybe that he's connecting right now. Melissa, do we have an update on Delegate Ampre?
Yeah, he's joining the room right now.
Excellent. So just so the members know, we have two panels on this bill. We have one panel of favorable, which is 3 people testifying, including the sponsor, and following that will be 2 favorable with amendments. Delegate Ampre, are you signed on? I see you, and you can go ahead and start introducing your bill once you're unmuted.
All right, can everyone hear me?
We can, thank you, welcome.
Welcome, thank you so much for having me. All right. For the record, my name is Delegate Marlon Ampry, here in support of House Bill 915, work group on Black, Latino, and other underrepresented mental health professionals. Thank you, Madam Chair and members of the committee for your time today. So the first thing I'll start with is just understanding that we are really currently in a public health crisis. As many people may already know, on this committee, we are in lack of more mental health providers as a whole in this nation and this state. Unfortunately, like many things that affect our nation and our state, this has an even larger effect on Black and Brown communities. House Bill 915 is being introduced for the purpose of studying the shortage of Black, Latino, or otherwise underrepresented groups in the mental and behavioral health professions here in Maryland, in order to eventually make recommendations on incentives and systematic changes and other methods that will be needed to increase the amount of providers from these groups. This bill is extremely important in ensuring that our diverse population has access to an equally diverse pool of providers. There's an abundance of research supporting measures to incentivize diversity among mental health providers. And unlike any type of medical or therapy that is provided, it's really important that there is a cultural and connection between the patients and those delivering services. The data that you will hear today will demonstrate that it is really, really critical that we work towards diversifying the field as soon as possible. Ethnic and racial minorities often bear a disproportionately high burden of disability resulting from mental disorders. For example, although rates of depression are current, and this is only based on the data we have because of those who go and seek out services, is lower in within the Black community at 24.6%. Than in the white community, which is at 34.7%. But within the Black and Latino communities, according to the data we have, is likely to be more persistent. And even within those numbers, the African-American community is 20% more likely to experience serious mental health problems than the general population. And again, this goes to it's not even that this data really shows that there's a propensity for one group to have more issues than the other. It's more so the data shows that there is a lack of treatment and services that are available to ensure that these individuals are able to get help as soon as possible. People from these ethnic minority groups are less likely to receive mental health care. For example, in 2015, among adults with any mental illness, 48% of those who are white received mental health services, compared with only 31% of Blacks and in the Latino community, and then 22% of Asians. This is likely due to several factors, including lack of access to insurance. We know that there's provider bias, there's a lot of stigmas associated with mental health, and it's a cultural mistrust of a healthcare system that has predominantly been provided by white care providers. People from racial and ethnic minority groups are often likely to experience racism, which the American Psychological Association has identified as a form of trauma. This can lead to PTSD and other psychological issues, which are unique lived experience of people from minority groups that are best understood by providers from the same background. And there'll be more data there's more data that we will be able to provide throughout the rest of today's hearing. And you'll hear from people who are providers, people who are community advocates, people who are elected officials who are working to deal with some of the traumas and issues that are facing the Black and Latino communities. And it's critical that the data shows that when people have a cultural connection to those providing those services, they're able to provide better services. Those individuals have more trust in the system. If the person that they're receiving services from looks like them and understands their cultural backgrounds. And there's also evidence that what it also does is it ensures that they will come back. Unfortunately, there's data that shows that whenever people receive services, mental health services that are not up to par or not connecting with them culturally, they then move away from ever seeking out services again. So developing policies that incentivize Black, Latino, and underrepresented minority health providers to serve diverse communities with complex historical and cultural needs is an essential step in improving mental health outcomes for an increasingly diverse patient population. The first step to doing this effectively is to understand the ground level needs and challenges through a work group composed of academic leaders with expertise in diversity and inclusion, as well as mental health professionals dedicated to this cause. So what this bill will do is it will create a work group that will report back in a year. And I think it's really important, outside of all the national data that we have to make sure that we have data that is specific to the needs here in Maryland, understanding our university networks, understanding our healthcare provider networks, understanding the different types of trauma that people face throughout the state, and how we can really address it. And I hope that this work group can get that done, and I urge for a favorable report.
Excellent timing, Delegate Ampry. And again, welcome to the HGO committee. Let's hear from Zeke Cohen.
Thank you, Madam Chair, and thank you to the bill sponsor, Delegate Ampry, for thinking outside the box on how we can address the looming mental health crisis that we face. My name is Zeke Cohen. I'm a proud member of the Baltimore City Council and sponsor of the Elijah Cummings Healing City Act, the first bill in the nation to comprehensively legislate trauma-informed care for a major city. Racial violence and discrimination are woven into the fabric of our country. The United States was founded with one population of people owning another population of people. Throughout our history, the laws and policies that we've written have shaped disparate outcomes in healthcare, education, housing, and every other institution, favoring white people over communities of color. The horrific, senseless killings of Black and Brown people played out nightly on television and in social media have added enormous trauma. Research shows that trauma, when left unaddressed, can lead to other health problems like heart failure, depression, anxiety, and can increase a person's likelihood of becoming addicted to substances, being a victim or perpetrator of violence, and even committing suicide. We have not recovered from what folks of color have experienced in this country or even really attempted to treat the wounds. According to the Anxiety and Depression Association of America, Black Americans are 20% more likely to report serious psychological distress than white Americans, yet they are less likely to use mental health services. Meanwhile, in 2018, the American Psychological Association reported less than 10% of psychologists in the United States are comprised of Black and Brown clinicians. We must do better in Maryland. Now is the time to enact this work group and bring bold ideas to the table. We know that seeing a therapist with a shared cultural background is healing. We know that we can and must incentivize more mental health providers of color to join the workforce in Maryland. Let's become a national leader. I urge a favorable report. Thank you.
Thank you very much. Let's hear from Dennis Antoine.
Thank you, Chair Pendergrass, Vice Chair Pena-Melnick, and members of the committee. I want to thank the bill sponsor, especially Delegate Ampry, for the opportunity to testify on this important issue. My name is Dr. Dennis Antoine. I'm a psychiatrist at Johns Hopkins, and Johns Hopkins is pleased to support House Bill 915. Diversity and inclusion is a core value of Johns Hopkins medicine, and our institution remains dedicated and committed to reducing health disparities that are present throughout the state of Maryland. Health disparities, unfortunately, have been a long-standing systemic problem in communities of color, and the COVID-19 pandemic has only further exacerbated these disparities and has heightened the need for legislation aimed at reducing the blight in our communities from mental health issues. Disparities are well known in the treatment of several medical conditions, and they are prevalent in mental health treatment as well. Providing access to high quality care would be one of the many potential effective strategies to eradicate these disparities. And while efforts to eliminate these disparities have not been successful in primary care or mental health outcomes to date, creating a diverse mental health workforce is an important step to eliminating these disparities in the future. The statistic that only 2% of practicing psychiatrists today in the United States are African American reflects part of the picture, but it also speaks to the fact that a lack of diversity of the available mental health provider workforce currently is an important barrier to eliminating these disparities. Low cultural competence in the form of language differences, stigmatization, inability to recognize cultural specific presentations contributes to underdiagnosis and or misdiagnosis of mental illness in communities of color and subsequent treatment errors. This chain of errors exacerbates existing health disparities in communities of color, creating a disproportionately high burden of disability due to unaddressed mental health issues. Therefore, in order to deliver high quality, culturally appropriate mental health care, it is critical to increase diversity of not only physician workforce, but also all mental health care professionals. Therefore, in conclusion, Johns Hopkins is pleased to support House Bill 915 and urges a favorable report of this bill. Thank you for this opportunity.
Thank you very much, Dr. Antoine. Do we have questions from the committee for this panel or the sponsor? I'll give you guys a second to raise your hands. And then if we don't have any hands raised, we'll move on to the panel of favorable with amendments. I don't see any. I do see a question from Delegate Charles. Delegate Charles.
Thank you, Madam Chair. This question is in regards to the amendments to this bill. Really want to know why those amendments were added and get a little bit more detail about it.
Yes, thank you, Delegate Charles. So we made some additional changes to the bill based on our conversations with those in the mental and behavioral health networks here in Baltimore, throughout the state. And we went ahead and changed the language so that throughout the bill, mental is now going to be replaced with the term behavioral because it will cover more of the actual, based on the Maryland code, it will actually have a larger umbrella and cover more of the services that we want to ensure they're included in the work group. So it includes everything that we normally have under the term mental, but also include things like people who suffer from addiction issues, people who suffer from other types of behavioral needs. So the term behavioral was a better term, technical term, to encourage that we have a true good fabric of some of the needs that are needed to taken care of. The other changes that were made is that we went ahead and spoke with some advocates who were concerned that there wasn't a work group. The work group didn't include associations or organizations that are primarily people of color working to encourage diversity within the field. So we're going to include some of those organizations, networks, or associations that are primarily made up of the underrepresented groups that we're trying to address here. And then the other issue was that the payor or the insurance community wanted to have a seat at the table, and I felt as though that it was important that they had some input, but I didn't want to make the work group too large. So we went ahead and allowed the work group to create subgroups or subcommittees where they can get information and get some reports without having too much influence from the insurance and payor community at the table. But they can at least get the information to make sure that, because these are the networks that actually create the places where people can get their care, we want to make sure that there's opportunity for them to have the work group to have some information from the payor community.
Madam Chair, I'd like to thank Delegate Ampry for his thoughtful response, and glad to see that he's bringing the insurance companies on board as well, with network adequacy being one of those issues that we want to focus in on. I think it's great to get them at the table as well. So thank you, Madam Chair, and thank you, Delegate Ampry, and welcome to HGO.
Thank you, Delegate Charles. Vice Chair Pena-Melnick.
Thank you. How do you feel if you know that each member of the committee has a question for you today? For them?
How would I feel if each committee? Hey, I would be excited, because it means if you ask questions that we care and I want to talk about this is an important topic. We can talk all day. Let's go.
It's what we usually do. It's what we usually do when people come, and we can't do it here, but we're sending it to you. But this is great. I appreciate the fact that you did. I reviewed the file, all that work to bring everyone together and all the amendments. And this is really an important issue. So thank you so much.
Thank you.
And a question from Delegate Krebs.
Thank you. Welcome to our committee. I was just wondering, we have some work going on currently with the Behavioral Health Administration that we put in place a while back, and they're funding 5 workforce expansion projects in partnership with the Maryland's historically Black colleges and university and the University of Maryland, and it's supposed to increase the underrepresented professions in behavioral health workforce. So how do you see this group working together with them? I mean, is it redundant, or are they going to work in partnership with them? How's it going to? It seems like a lot of it is similar what they're working to do. How do you see these two?
So I'd have to get more information on the work group that you're describing in order for me to give a thoughtful answer on how this work group is possibly different. I think one thing that separates this work group from other work groups is the fact that, based on the amendments that we're adding here, we're including those groups and those majority minority networks and groups that are already doing some of the work to diversify the field. And by them being an initial member of the table, at the table, it will ensure that there is discussion and they're getting a true understanding and glimpse of what is currently being done, what needs to be done. And I think that ultimately, I have to see this other work group that you're describing to see what the differences would be here. But I, you know, at the end of the day, I think this bill is a really good bill that really addresses the issues that we really have in diversifying the field. Because I mean, it's just, I can speak to my, you know, well, I don't want to go long into answering this question, but it's, you know, everyone I've spoken to anecdotally in the area, it's really hard if you're a person of color to go find someone that you can trust to have to find a therapist, a psychiatrist. It is really difficult. And you know, it's
not arguing with your motivation.
Yeah. So I think
make sure we're not being redundant. So there's some make sure there's some synergies.
Yeah, definitely. So I have to look at other work group before I can answer to ensure that they're I can just speak to the differences.
Excellent. Delegate Krebs, does that answer your question? Yes. Okay, so I'm looking for any more questions from members of the committee. I don't see any more questions. We do have a favorable with amendments panel, so let's call up Bobby Holmes.
Good afternoon, Madam Chair and committee members. Hope everyone is doing well. I first want to begin by thanking Delegate Ampry for bringing this bill forward. It's much needed. I'm Bobby Marvin Holmes, founder of Son of a Dream and a licensed social worker serving children, youth, and families in Maryland. I have been working in the mental health profession for nearly a decade. I'm proud of my work and the families I serve. However, my colleagues and those seeking services often remind me that the need for more Black men in social work is still great. Parents have also emphasized the need to have clinicians of color who look like them and share similar experiences. These shared lived experiences and insight can be critical in building rapport and making progress in treatment. Of course, I cannot serve everyone. At my agency currently, I am only one of 2 clinicians of color on staff full time. I am also the only man offering psychotherapy on staff full time. Other mental health agencies and community members often contact my agency seeking Black male clinicians. However, there are times where it's not possible. To help address this problem, I'm in support of House Bill 915 with amendments. I believe more clinicians of color will help challenge the stigma around mental health, increase connection to services, and improve the quality of services. To help achieve this goal, instead of representatives from hospital networks, the work group should include professionals that have expertise in race equity policies and practices. The work group should also include representatives from mental health organizations led by people of color, that at least 50% of the staff reflecting the leadership. I believe that better demonstrates a commitment to increasing clinicians of color in the mental health field. The committee's vote for this bill is a step toward obtaining that goal. Thank you.
Thank you, Mr. Holmes, and thank you so much for the work you do. Let's hear next from Allison Taylor.
Good afternoon, Madam Chair and members of the committee. My name is Allison Taylor here on behalf of Kaiser Permanente. Today, we're in strong support of this bill and thank Delegate Ampry for bringing it. Our interest is in a couple of ways. We're strongly committed to health equity and diversity for the reasons that a number of the previous witnesses have mentioned, so I won't repeat it. Additionally, Kaiser Permanente is a major employer in the region. We employ over 5,000 healthcare workers in Maryland alone. The recruitment of behavioral health providers, and particularly those from underrepresented communities, is a challenge for us in Maryland and nationwide. There are nationwide shortages. So we have an interest in being involved in this work to the extent it can help develop a pipeline that we'd be able to recruit from and that others would as well. Secondly, as was noted by the bill sponsor, the payer community is interested in this legislation because, as you know, we've worked closely with the committee and with the MIA over the years on network adequacy. We're responsible for maintaining an adequate network in Maryland, including of behavioral health providers. And so any effort that can help increase the supply of those providers who can be in our networks is of major importance to us. So with that, we recommend a favorable report with the amendments that Delegate Ampry has worked on, and thanks for the opportunity to testify today.
Thank you so much. Do we have any questions from members of the committee for this panel? I'm going to give you all a second to raise your hands. And while I'm giving you that second, I'll just note for the committee that there is also a tremendous amount of written testimony in support of this bill in your file. So there's a lot of written as well as the panels we've had. I don't see any questions. So with that, this concludes the hearing on House Bill 915. Thank you so much. We're going to move on. Thank you so much. Welcome again.
Thank you. Thank you.
We're going to move on to House Bill 919, which is Delegate Bagnall's bill, Maryland Insurance Commissioner, Specialty Mental Health Services and Payment of Claims Enforcement. Delegate Bagnall.
Good afternoon, Chair, Vice Chair, and members of the committee. For the record, I'm Delegate Heather Bagnall testifying on behalf of HB 919. You have my written testimony, so I'll summarize. HB 919 is an emergency bill which requires the Maryland Insurance Commissioner enforce a provision of the law 15-1005 of the insurance article, which for efficacy is defined in my written testimony, but it concerns delivery of specialty mental health services by managed care organizations and administered by the Administrative Service Organizations, or ASOs. In January of 2020, the Maryland Department of Health began using Optum as their ASO. By April, it was clear the transition was problematic and MDH began authorizing estimated payments, which ended in August. In November, when Optum came before the Senate, they admitted there was a problem, saying they were disappointed by the rollout. That disappointment has caused a serious crisis within the behavioral health community. Throughout this pandemic, behavioral health providers have continued to provide services, yet have gone months without reimbursement. Community Behavioral Health surveyed their members ahead of this hearing, and just within their membership, those reimbursements were approximately $60 million. Trying to get relief, CBH called upon the MIA, who raised a concern that they did not have enforcement authority, a concern reinforced when they sought an opinion from the Attorney General. HB 919 will clarify MIA has the authority to enforce. Without this enforcement and relief, we are exacerbating a significant public health crisis. We risk the loss of coordination of care. We will see providers who will be forced to simply refuse to accept Medicaid, resulting in network adequacy issues and deterioration of patients. These are our most needful patients in the middle of the greatest public health crisis in a century. The cross-file of this bill had a hearing yesterday, and we are coordinating these bills together to start the process and provide relief as quickly as possible. I'm going to cede my time to Lori Doyle, and I'm asking for a favorable report.
Thank you, Delegate Bagnall. Let's hear from Lori Doyle.
Thank you, Madam Chair. Lori Doyle here on behalf of the Community Behavioral Health Association of Maryland. And I want to start by thanking this committee for keeping this Optum issue on your radar, culminating in the briefing that Delegate Bagnall mentioned last November. And also thank all the members who stood up and personally interceded on behalf of providers in their communities. It was very much appreciated. Unfortunately, since Optum went live again last August of 2020, the problems persist. And Delegate Bagnall mentioned our outstanding receivables of about $60 million. That does not include solo practitioners who may just decide not to take Medicaid patients anymore because of the hassle with trying to get paid. So in desperation, we did go to statute to find that indeed, Health General says that the ASO has to comply with subsection 15-1005 of the insurance article. And that article says that the ASO and other insurers have to do one of three things within 30 days. They either have to pay the claim, they have to send provider notice that there's a reimbursement dispute, or they have to tell the provider that the claim is not clean and what they need to do to make it clean. And there are interest penalties and fines associated. We went to the MIA with that information, and they were very, very helpful. They asked us to submit some claims to them, which we did, but they also expressed the fact that they thought they did not have jurisdiction, and the AG concurred with that. So they then forwarded the claims that we submitted to them to MDH. That was in mid-January. We have heard nothing back. We agree that the claims that we're talking about here are post-August 3rd. MDH raises that in the fiscal note, so I want to make clear that we're talking about August 3rd and beyond. And it also, though, makes clear that it ought to be an automatic interest penalty payment, that the individual who puts the claim in doesn't have to go back in and put in another claim for interest payment. It ought to be automatic. We've raised these issues for some time now, and the response has been that everything's going fine. To the extent that there's a problem, it's provider error. Our providers have been doing this for many, many years. This is their 4th ASO. They did not just forget how to bill. In fact, they mostly use electronic health records that are programmed to catch mistakes before the bill is even submitted. And honestly, if Optum is truly paying as they say they are, they have nothing to fear from this bill. So I'll close by saying, the General Assembly has limited power over this issue, but this is something you can do, because if the MIA can't hold Optum accountable and MDH won't hold Optum accountable, then it in fact nullifies the very statute that you all put into place to protect providers in circumstances just like this. So I hope you will provide this bill with a favorable report. Thank you.
Thank you, Ms. Doyle. Jeffrey Richardson is next.
Thank you, and thank you, committee. My name is Jeff Richardson. I'm the Vice President and Chief Operating Officer at Sheppard Pratt. And I have to tell you, this is the 3rd ASO transition I've been through in my 30 years as a behavioral health provider. And we can really no longer call this a transition. It's been going on for over a year. We can call it a train wreck, because I've never seen anything like this. As many of you have already mentioned, we are in a behavioral health crisis right now, along with a pandemic. So our focus shouldn't be on chasing down bills that we should already get paid for, but actually focused on the care and delivery and expansion of access on services. We continue to have challenges with authorizations, sometimes with no explanation, processing issues, overpayments, underpayments on certain services, and we're even still receiving claims for providers that aren't Sheppard Pratt. So there are patients that we're getting paid for that aren't even our patients. So we continue to have struggles with this. One of our organizations had 23% of claims denied, and an additional 12% were disallowed, resulting in millions of underpayment. Based on data we have pre-Optum and data Optum provided, they are denying and disallowing about $12 million net over what Beacon had already approved for us prior. Until we received assistance from the state, that number was at 24 million. We have 30,000 claims submitted with no response from the Optum system, 335,000 claims over 30 days. So there's no integrity to this data system. Our staff are spending an enormous amount of time trying to take care of this. At the same time, we need to be focused on care and delivery and support of the folks that we are here to support. So I'm asking for your support of this legislation and help us refocus our energy on the people who need us most. Thank you.
Thank you very much, Mr. Richardson. Sue Ann Blumberg is next. Sue Ann, are you here? Melissa, do we know if Sue Ann is here?
I'm here. I'm here.
Okay.
I was on mute. I'm one of those people.
No,
Sorry.
it happens to all of us.
Sorry. Hi, I'm Sue Ann Blumberg. I'm the CEO at Upper Bay Counseling and Support Services. We serve both Hartford and Cecil counties. I would like to share with the committee the impact that Optum has had on our ability to receive payments and what the impact it's had on us financially. At this point, we are in a financially unstable situation. The absence that I can tell you, the financial impact on Upper Bay is astronomical. As of January 31st, our accounts receivable for over 120 days was $796,512, or 59% of our Medicaid receivables. For comparison, the other ASOs, that number was at 3 to 5% and of Medicaid receivables, and the issues that created those bills from being paid were easily identifiable, easily remedied, and typically with the help of the ASO. The absence of a basic revenue cycle management tool has made our ability to receive payments that match our records near impossible. We have a billing manager who has been with us for 28 years. She has been through every transition into a new ASO, and 2 weeks ago hit her breaking point. We had to actually send her on vacation for a week, and I spent a week praying she didn't quit, because then I don't know what we would do. We've had to hire new billing staff, which are non-revenue producing positions in a time when we need revenue. The services that are needed more than ever right now are being sucked away because so much time is being spent on us working through this billing system. I really ask for your favorable report on this bill to help us.
Thank you very much for your testimony. We have Scott Becker next.
Good afternoon, Madam Chair and members of the committee. My name is Scott Becker. I'm the Chief Financial Officer for Catholic Charities of Baltimore. Catholic Charities provides care and services to Marylanders throughout Central and Western Maryland. Among our many programs, we provide outpatient, clinic-based behavioral health services in Anne Arundel, Baltimore, Frederick, Harford, and Allegheny counties, as well as Baltimore City. In addition to clinic-based services, our therapists provide school-based care to children and youth in more than 120 public schools. In total, we engage in about 11,000 billable behavioral health encounters each month, all processed through Optum. Within my finance team, I too have a small group of long-tenured expert billings and claims management professionals who also have worked through 3 different ASO transitions. And I can confidently say, like the others, that my team has never seen anything like what we've experienced over the 13 months. Since the transition to Optum began in January of 2020 through August, Optum was unable to process individual claims for these critical services. Instead, we received estimated payments arbitrarily based on prior year activity. Since last August, claims-based payments from Optum have been equally unreconcilable to our billing records, again, at a pace of 11,000 sessions per month. So from January of 2020 till now, a period of more than 13 months and 150,000 encounters, we have amassed approximately $15 million in unreconcilable payments from Optum. As a result, our books are an unacceptable mess. I have no idea how or by when we will be able to clean up the mess of the past 13 months. And I am extremely troubled by that, as is our board. What's worse is that with each passing day, the issue only grows larger for Catholic Charities and the broader provider community. It is therefore imperative that this ASO be subject to the additional oversight and accountability standards that this bill provides. Thank you for the opportunity to testify. I urge you to issue a favorable report on this bill.
Thank you, Mr. Becker. And the final person testifying in support of this bill is Tony Torsch.
Hi, good afternoon, Madam Chair. I'm Tony Torsch, and I have a position with Maryland Coalition of Families, as well as I'm the director of the Daniel Carl Torsch Foundation. So it sounds like you're hearing from a lot of large organizations. So I'm a very, very small fish in this. So I just wanted to share my experience since Optum has taken over, is that normally our funding, and that's our mission is to, for the Daniel Carl Torsch Foundation, is to assist people into substance use disorder treatment and recovery. Normally our funding is about $2,500 a month, and that could serve anywhere from 10 to 15 individuals. By June, it had increased to 98.5%. So we were helping about, it totaled about $15,000. So it doesn't sound like a lot of money, but to someone that just only fundraised at $30,000 is a tremendous amount. Due to homes, some of the recovery homes that we help people, we fund, were closing their doors because of the delay in Optum reimbursements and payments. And so what I feel that that it needs the oversight. Optum needs this oversight from the Maryland Insurance Administration. And the citizens of Maryland, we deserve it. We deserve more the organization than the chaos of what's happening right now with Optum. I'm asking for a favorable vote. Thank you so much for your time today.
Thank you very much, Ms. Torch. And as I give the members a minute to raise their hands if they have questions, I again want to note that there's a lot of favorable testimony in the file that was submitted as written. We have a question from Delegate Cullison.
Thank you very much, Madam Chair. And I want to thank you all for coming and providing us what it looks like on the ground, what the experience has been on the ground. And anyone can answer this. We heard a presentation from MDH, I believe it was in October, with respect to how they were making efforts to improve and had indeed made changes in the way that they were operating so that they could, be more timely and efficient in reimbursements. Have you seen an improvement since October, or all of the issues continued in the way that they were prior to then?
This is Jeff Richardson. I would say that we've seen it is a moving target. Some get fixed, new problems pop up and replace them. It has been a very inconsistent, very awkward and disorganized system. For a company that's a $260 billion entity, I've never seen anything like it. So yes, we continue to have problems and new ones. And the old ones sometimes get fixed, and then we have to put a lot of effort into going back and fixing them again.
Thank you. That's very helpful. Thank you.
Delegate Riley.
Thank you, Madam Chair. It looks like I have a copy, I guess everybody has it in their packet, a copy of a letter that was addressed to Senator Hershey. I guess it was given to the Senate side when they had their hearing. And I found it quite interesting. It sounds like this same company has a contract with the District of Columbia. And it looks like for many years, 15 or so years, they have struggled with the same situation that we're struggling with now. And the businesses, that are here now, Upper Bay Counseling and so on. I mean, can you imagine going through what you're going through now in this last 13 months for like 15 years and it's still not what would happen to your business? And any of you can answer that.
I mean, the reality is the business is one thing, the services would go away.
Absolutely.
I mean, this is we are providing a public service to the community. These are folks that are most vulnerable, and we simply wouldn't be able to do it. And the DC system has suffered. Our system will suffer and has been one of the best in the country and will slowly and certainly deteriorate if this isn't fixed.
I'd like to add my counterpart that does.
I'm so sorry. We have one question, one answer in this committee. It's just one of our committee rules, but we can certainly talk to you offline about that. Delegate Krebs.
Thank you. And I guess I asked Mr. Richardson. So back when we had our meeting with Optum back in the fall, they explained about these estimated payments and how they were going to catch up. But it sounds like what you're saying, tell me if I'm wrong, you still don't, do you have a way to look at these payments and know what they're even being posted to, what you're being paid for, so you can reconcile your receivables? I mean, are there any kind of reports that are coming to you saying, yes, we're catching up here, or is there no way to reconcile what you're doing?
I'm going to say no on our behalf, but I'm going to let Lori answer it on behalf of all of our members.
Thank you, Delegate Krebs. And that's one of the major issues and the reason why this bill is in, because we're not getting those kinds of reports that let us know and let us post and let us do our revenue cycle management. Part of the issue with Optum is that they continue to process and reprocess the same claims over and over again. And so we have to manually go through literally tens of thousands of lines of data to track down these claims, which scares us half to death when we come to paying back those estimated payments, because we don't trust Optum's math and we have no way of verifying it. So it's a huge issue, and it's part of what's in the requirements in the insurance article, that we be told within 30 days if the claim is not clean, why it's not.
Sounds like a boondoggle.
Thank you, Delegate Krebs. Delegate Saab has a question.
Thank you, Madam Chairman. if anyone can answer this question, what is the, so I understand there's an impact on your payroll and being able to keep the lights on and meet your payroll needs, but what kind of impact did it have on your billing team? Because obviously you're billing and rebilling and trying to focus on the issues. I mean, how much money are you wasting trying to collect money that is owed to you?
Delegate, who are you directing that to?
Anyone can answer the question that has.
I will say that our billing team from Catholic Charities has been incredibly distracted and sidetracked for a 13-month period. We have many other issues that are critical to the support they provide to our programs. And the amount of confusion, uncertainty, lack of information, overtime, stress, and so forth has just been incredible on the small team that really does not need to work with a provider of that scale with something that should be as straightforward in terms of processing as billing and claims management. Just extraordinary.
Thank you. And that takes away the core business, which is actually delivering service, not collecting money. Thank you. I appreciate it.
About it.
Delegate Kipke.
Thank you, Madam Chairman. I was just curious if this is the appropriate time to move the bill, or do we need to wait until the voting session?
Who's that question directed to, Delegate Kipke? I believe that is a question for the chairman, for the actual chairman of the committee.
I just have this incredible headache and anxiety listening to this whole thing. I feel terrible that everybody's still going through this. I contacted a constituent who's a social worker, and I said, is Optum still a problem? And I felt like I was giving her therapy for the last 5 minutes. So I'm just so sorry and can't wait for us to get a chance to vote on this bill. Thank you.
Thank you, Delegate Kipke. Delegate Hill has a question.
Thank you. First of all, Delegate Bagnall, thank you so much for this bill. I'm not sure it's going to do what it needs to do because I'm not clear what the problem is. Ms. Doyle, I know it's been this roller coaster ride of promises and failure to fulfill the promises. Do you have any idea what the problem is right now? If it's a system problem, a computer problem, they don't have the money to pay. Do you have any idea what the problem is?
I think Delegate Riley with her question basically pointed to the problem, and that's this sub-vendor to Optum. In Maryland, it's called Encato. It was called something else in DC, but our understanding is and our experience is that it is just not up to a system of this magnitude. We have a pretty comprehensive and complex public behavioral health system, and this sub-vendor just cannot deal with the complexity of our system. And so it doesn't matter how much work and time people put into it. It's like a bad EHR. It doesn't matter if the platform's bad, it will always be bad. And I think that's what we're dealing with here.
So not really replicable, need a new vendor. Need a new vendor. Okay,
at least a new sub-vendor. Thank you.
Okay, Chairman Pendergrass.
Thank you, Madam Chairman. No, I'm not going to answer your question, Delegate Kipke, but I appreciate you asking it. And I appreciate the fact that everybody on this committee is acknowledging that this is really unacceptable, just totally unacceptable. I want to say, having looked at my file 3 times, the administration chose not to even weigh in on this bill. I mean, at least usually they say something about informational, and in this case, they chose to just be AWOL. And I'm not sure what to do about it, but I'm sure that with the people we have on this committee, and I include both parties equally, we're going to figure out what to do. I don't know that we can solve the problem. We need some sign that the administration is listening and is trying to solve the problem. I think that that's the message that you're sending to us. And I think you've run out of patience, and I think we're where you are. And this bill may have to pass. We'll see. But thank you very much for being here today. And thank you, Madam Chair, for letting me give a little speech, which was totally breaking the rules.
the chair is allowed to do that once in a while. Delegate Lewis Young.
Thank you, Madam Chair. I'm not sure who to direct this to. I'm sure the appropriate person will answer. But given some of the circumstances I've heard, don't you think that perhaps this whole scenario could be, should be the subject of an audit by OLA?
I don't know. Honestly, that's probably beyond my scope of understanding, but certainly something's got to be done to look into the fact that these folks keep getting paid for a contract that they are not meeting the deliverables on. And I'm not sure who that is because, you know, the contract is with the department, but it's a very good point. Thank you, Delegate.
Yeah, I'm on the audit committee, so let's connect offline and I'll figure out how to make that request go forward.
Wonderful. I'm seeing no more questions from members of the committee who have yet to ask a question on this. So we do not have anybody here in opposition to the bill. So that concludes the hearing on House Bill 919. And we are moving on to the final bill of the day, which is House Bill 970, Delegate Johnson's bill, the Psychology Interjurisdictional Compact. Delegate Johnson.
Thank you, Madam Chairman. Before I get started, if I could just give you the lineup for the witnesses in the order they would like to be called in, would that be okay?
I think I have them. I received an email.
Oh,
So we'll
thank you.
start with
Okay,
Paul
thank
Bergman.
you.
Yeah, sure thing.
Yes, thank you very much. All right, thank you, Madam Chairman, committee members. It's good to be presenting my last House bill of this session before my own committee, Health and Government Operations. For the record, my name is Delegate Steve Johnson, here to present House Bill 970, the Psychology Interjurisdictional Compact, known as PsyPact bill. We've heard in this committee many times, as we did again today, on the presentation of House Bill 915, that we have a shortage of psychologists here in Maryland. And it takes a while to get appointments when these folks need to have an appointment. Here we have another compact bill. But the reason we have all these compact bills this session is because COVID has proven to us that they help, they work, and they've opened up access to the mental health and substance use treatment in a way we never thought possible. It has also been proven to be beneficial to those with autism spectrum disorder, language barriers, transportation issues, mobility issues, individuals with significant time constraints such as caregivers, those who work multiple jobs, college students, and the list goes on and on. We've also found that people keep their appointments because of the convenience. Research has shown these services are effective and offer additional benefits such as increased accessibility, flexibility, and affordability. PsyPact is currently enacted in 16 states and jurisdictions effective March 1st, 2021. Maryland is the only jurisdiction in our region which is not yet included in PsyPact. The District of Columbia, Pennsylvania, Delaware, and Virginia are all active PsyPact members. West Virginia is expected to introduce PsyPact during this legislative session. Lieutenant Governor Rutherford also supported the concept of mental health interstate compacts during the governor's press conference on January 14th, 2021. Now, normally we like to bring everyone to the table to discuss and work out all concerns. We did have one meeting with myself, Delegate Collison. Thank you, Delegate Collison, for sitting in on some of these meetings with me this interim and during this issue. The Board of Examiners of Psychologists and the Maryland Psychological Association. After that, there was some resistance. Delegate Collison and I had a couple more meetings with the Board of Examiners, and I had additional meetings with the Psychological Association. So what I'm going to do today is have the panel of subject matter experts explain the bill and address all of the concerns that the Board of Examiners have which, by the way, are the only unfavorables today. I urge a favorable report, and I would like to yield the rest of my time, Madam Chair, to Dr. Berman, if that's possible.
Absolutely. Let's make sure, Melissa, we can give Dr. Berman a 4-minute time clock. So we'll add Delegate Johnson's to his 2 minutes so he has enough time to explain things. And while we give Melissa a second to do that, Delegate Berman, I'm sorry, Dr. Berman, could you please get yourself ready to speak?
Thank you very much, Madam Chair, Madam Vice Chair, and Melissa, thank you for getting the PowerPoint up and running. My name is Paul Berman. I'm a licensed psychologist in Maryland and appreciate the opportunity to testify on behalf of the Maryland Psychological Association and its 1,000 members on behalf of House Bill 970. And thank you very much, Delegate Johnson, and for your assistance, Delegate Cullison, in sponsoring this bill. Next slide, please, Melissa, if I may. House Bill 970, as Delegate Johnson said, is an interstate compact. There are currently 14 states that participate in the compact. There are an additional 2 states that will be coming online March 1st, sorry. And in the Mid-Atlantic region, as Delegate Johnson said, DC, Pennsylvania, Delaware, and Virginia are currently members. PsyPAC allows doctoral level psychologists to practice in 2 ways. One is via telehealth from a PsyPAC state to another PsyPAC state. And the second way is via in-person practice for up to 30 days in another PsyPAC state. In addition, PsyPAC specifies which state laws supersede other state laws. As members of the committee know, different states have different laws with regard to administrative issues such as record keeping, but clinical issues as well, such as involuntary hospitalization, commitment, and guardianship. And PsyPAC specifies which state laws supersede in which circumstances. In addition, PsyPAC specifies the disciplinary action required of the different boards. Next slide, please. This slide shows that in addition to the 16 states which have passed it, which have passed PsyPAC, there are an additional 14 states which have introduced PsyPAC this year. So the potential is for up to 30 states will be participating in PsyPAC by the end of 2021. Next slide, please. It's important to be clear that the criteria for licensure in Maryland are exactly the same as the criteria required for participation in PsyPAC. It is a doctoral degree, and the program must be accredited by the American Psychological Association or the Canadian Psychological Association. I apologize for the typo, or a program designated as a psychology program by the National Register. Next slide, please. This slide lists the criteria required in our licensing law, Maryland Health Occupations article, Title 18, again, doctoral degree, and that the program must be accredited by APA or CPA or the National Register. Next slide, please. Similarly, in PsyPAC, you'll see in this bill, House Bill 970 on page 9, 10, 12, and 13, that PsyPAC requires an e-passport or an IPC, interjurisdictional practice certificate, with exactly the same criteria as that required by Maryland licensure, which again is the doctoral degree and the accredited programs. Next slide, please. Under PsyPAC, it is not possible for a psychologist with anything other than a doctoral degree to participate. And the reason I'm emphasizing this is because you will hear from the opponents that PsyPAC could allow someone with a master's degree to practice, and that is simply inconsistent with the legislation, the commission rules, and the other criteria. 2 other points, if I may, that I will make very quickly. One is that the executive branch, as Delegate Johnson said, does support interstate compacts and does not see their bill, the governor's bill, as a substitute for compacts. And finally, not only does SIPAC allow for continuity of care and increased access to care, but allows it under a limited and minimal administrative burden. We would pay one fee to obtain the criteria or the credentialing necessary, which is $400, an additional $100 per year. If you compare that to the licensing fees in the various states, just the Mid-Atlantic region, we would be paying upwards of $1,500 a year just for the 4 or 5 states in the Mid-Atlantic region. So this SIPAC decreases the administrative burden and allows increased access to care and ongoing continuity of care. Thank you very much for your support. We ask for a favorable report on House Bill 970, and I'll now turn it over to my colleagues, and I appreciate your time and interest.
Thank you, Dr. Berman. We will now hear from Pat Savage.
Hi, good afternoon, Madam Chair and Madam Vice Chair and members of the HGO Committee. My name is Dr. Pat Savage. I appreciate this opportunity to address you. I am a licensed psychologist practicing in Maryland since 1986. I work with children, adolescents, young adults, adults, and families. I've also provided you with extensive written testimony. Today, though, I appear before you to share a story that illustrates the profound good that SIPAC can have upon the lives of Marylanders. I, as well as other healthcare providers, were invited by a family to support the development of their young child into an independent adult. The child was diagnosed with autism, one of a number of developmental disorders that provides a multitude of challenges to the individual diagnosed, as well as to family, friends, educational, and social systems. With compassionate, coordinated care and strong family support, this individual was able to complete high school, develop the skills to participate in church and community groups, achieve several leadership positions, and enter into college. All of this in spite of intense storms of frustration, confusion, anxiety, depression, self-doubt, and even at times self-hatred. Despite a significant setback, withdrawing from an out-of-state college, due to this person being unable to access their trusted healthcare providers during an emergency, upon returning home, they regrouped and were making progress until the primary earner in the family unexpectedly lost their job, requiring the family to quickly move to another state. This event would have prevented the person from continuing their relationship with their treatment team, except for the health emergencies put into place by the COVID pandemic. The new goal, transition care to a home state team. The disruption in this young person's life overwhelmed their ability to cope, resulting in an aborted suicide attempt. Fortunately, they reached out to their trusted healthcare professionals, used emergency procedures, and survived this episode. Without the COVID emergency declarations, the results of this situation might have ended in tragedy. This is one of many stories about our attempts to provide care to an increasingly mobile population. I ask that you provide a favorable report on SIPAC. We mental health care professionals and the clients who seek our help in Maryland need the mechanisms in this bill to provide care now. Thank you for this opportunity to testify.
Thank you very much, Dr. Savage. Now, Linda McGee.
Good afternoon, members of the committee, Delegate Johnson, Delegate Cullison, and Chairman Pendergrass. I want to talk in support of, I'm the president-elect of the Maryland Psychological Association, and I want to speak to you today on continuity of care. Continuity of care for Maryland residents is a paramount concern. The effectiveness of therapy is largely dependent upon establishing a therapeutic relationship and continuing care if a client geographically relocates. In my practice, I treat teenagers and college students who regularly transition from high school to college. SIPAC would allow me the ability to provide care during this critical transition from high school to college, from college to post-college, where relocations are frequent. Likewise, it would allow out-of-state students from Maryland universities to continue their care with their home state care therapists. Under current law, if my Silver Spring-based college student goes to Penn State, I am unable to treat them as I have no license in Pennsylvania. I'm often forced to transfer the care of vulnerable clients due to laws made decades ago. COVID-19 gave us some temporary respite, but those temporary licenses are expiring. There are two underserved communities that I hold near and dear. One is the rural communities. There may be only a few therapists in the area, and oftentimes the mental health professionals either may not be a good fit or may not provide service due to not having experience in the specialty needed, or the psychologists may have dual relationships with the client, which are often prohibited. In addition, we are nationwide, our African-American communities, there are over 1.8 African-Americans in Maryland. As of today, there are only about 150 licensed psychologists. The predominantly Black counties such as Baltimore and Prince George's have the most severe shortages of psychologists. Therefore, in light of these shortages, I ask that you make services available to the maximum number of Marylanders and that you pass SIPAC. Thank you.
Thank you very much for your testimony, Dr. McKee. Now we will hear from Mary Alvord.
Good afternoon. Thank you. This is Mary Alvord. I have been licensed in Maryland since 1979 and have been promoting telehealth actually for more than a decade now. Since the beginning of the pandemic, I've trained 10,000 mental health professionals across the country because there's such a great need, and the issues are really the same for all of us. I have an office in Chevy Chase, which is less than 2 miles from the district line, and an office in Rockville, and it's a large group practice that's very close to Virginia. So I wanted to talk today just really about also reinforce the idea of continuity of care, but also collaboration. Our practice services several hundred clients a week. The primary population are children, teens, and their families. And they often require specialized care as well as carrying multiple diagnoses. So it's complicated, but the care is not just the child or the teen. It includes the family members and the caregivers. One child often has more than 2 homes because of separation, divorce, which may actually take place anytime during the course of treatment. And we need to be able to cross the jurisdiction to provide that continuity of care. Also, parents often might work in the district, and it especially hampers and I think becomes an equity and an economic factor when they have to take many hours off to participate in their child's treatment. So I urge for continuity and for collaboration of care that this be passed. Thank you.
Thank you very much, Dr. Alvord. We now have one final panelist to speak in support. That's Christopher Arnold. Welcome back.
Good afternoon, Madam Chair, honorable committee members. The Department of Defense expresses its support for Maryland House Bill 970, SIPAC, which addresses licensing issues. My name is Christopher Arnold. I am the Northeast Region Liaison at the Department of Defense. And as the First Lady reminded us last week, helping military families on licensing issues through legislation is not merely the right thing to do, it is critical to our national security. Occupational licensure compacts provide consistent rules for licensed members to work in other states. Common misinformation about compacts is that they either lower or raise the standards for an occupation, when in fact, compact states have the option to issue a compact license and also a state-only license to maintain their state standards. In 2018, the Secretaries of the Army, Navy, and Air Force issued a policy memorandum to the National Governors Association, noting they will, quote, consider the quality of schools near bases and whether reciprocity of professional licenses is available for military families when evaluating future basing or mission alternatives. The Air Force's approved criteria assesses states' policies for accepting professional licenses for psychologists as part of its strategic basing process. Full credit is only awarded for SIPAC. States have committed to using interstate compacts, which establish common understanding of competency and its measurement within the occupation to resolve the interstate issue of license portability. SIPAC has been created to facilitate telehealth and temporary in-person face-to-face practice of psychology across jurisdictional boundaries. Under SIPAC, a psychologist can obtain an e-passport to practice telepsychology and or conduct temporary in-person face-to-face practice. A doctoral degree in psychology is required to obtain the e-passport. SIPAC is of dual benefit in that it not only expands access to care for the military service members, but also allows military spouses who are practicing psychologists to conduct interstate practice via telehealth or in person. SIPACT allows an active duty service member or their spouse to designate a home state where the individual has a current license in good standing. The state then serves as the individual's home state for as long as the service member is on active duty while adhering to the laws, rules, and scope of practice in Maryland. The Secretary of Defense has established spouse employment as a line of effort in the National Defense Strategy, and the secretaries of the military departments have also expressed the importance of military spouse licensure by making it part of the consideration for future mission basing. We appreciate the opportunity to support the passage of House Bill 970 and the enactment of SIPACT, and are especially grateful to Delegate Johnson for introducing this important legislation. Thank you.
Thank you, Mr. Arnold. Do we have questions for this panel of proponents from the committee? I'll give you a second to raise your hands. I'm seeing them pop up. Delegate Charles has a question.
Thank you, Madam Chair. Delegate Johnson, I want to thank you as a military veteran. I want to thank you for bringing this bill forward, because I think we definitely need more compacts like this that'll help veterans and their spouses as well. During your testimony, you had mentioned something about some of the issues and the resistance that you were dealing with in the meeting. Can you kind of go back to that and tell us where that resistance was coming from?
Thank you, Delegate. The resistance actually wasn't in a meeting, it was to a meeting. The board made it quite clear that they had no further wishes to meet with the association. So we had to end up meeting with them separately. But on important bills such as this one, even though sometimes it may be disoriented, we'll work through it and do what we have to do to work out a good bill. And if that means meeting with them separately, that's what we'll do. Thank you.
Thank you, Delegate Johnson. Truly appreciate you.
Another question from Delegate Bagnall.
Thank you, Madam Chair, and thank you to the bill sponsor for bringing this bill. Can you just explain what is the pathway for Maryland psychologists to continue providing treatment to patients that are out of state? Does it require a license in that state?
No, I'd be happy to answer that. This is Dr. Berman. Yes, each state has its own license. So in Maryland, I need to be licensed. If I were to practice in the District of Columbia, then I would need to be licensed in the District of Columbia. Or if I was treating a Maryland patient or someone who lived in DC, came to my office in Maryland, but I had to talk with their parents at home in DC. I could not do that because then I'd be practicing across state lines. So I need to be licensed in DC. So one needs to be licensed in every state in which you want to practice, unless there is an interjurisdictional compact like SIPACT.
Thank you so much.
Thank you.
Next question is from Delegate Hill.
Thank you. It took a while to find the thing. Thank you, Madam Chair, and thank you, Delegate Johnson. Dr. Behrman, you spent a great deal of your presentation trying to answer one of the board's concerns having to do with who exactly the PAC would allow to practice. And you said it would only be psychologists, meaning people with a doctoral degree. But on the bill, on page 9, as they point out, it does say that you can hold a graduate degree in psychology, which could be a master's, obviously, from an institute of higher education. Why can't you, or can you, put the language that you showed on your slide as a substitute into this bill to address that issue and give clarity? Or is that not necessary because I'm not clear, the information you gave seems to say it's not indicated and that the board is wrong. So can you help me to understand the board to understand why they're wrong when this is the language that's written in the bill?
Yes, thank you for your question, Delegate Hill. So the legislation, as you said, does indicate the definition of a graduate degree as a doctoral degree or a master's degree. However, in the commission rules, which are in attachment 1 of the testimony that I submitted, the commission rules specify that a graduate degree is a doctoral degree. In addition, the legislation specifies that a psychologist needs an e-passport or what's known as an IPC, interjurisdictional practice certificate, in order to meet the criteria for SIPAC. And both of those, also in attachment 1, require a doctoral degree. The reason that it cannot be put in the legislation is because, as I understand it, the legislation has already been passed in 16 states, and in compacts, it must be the same legislation that is passed in the various states. So in addition to that issue, in my view, it is certainly not necessary because the commission has already specified in its rules that doctoral degree or graduate degree is a doctoral degree, e-passport requires a doctoral degree, IPC requires a doctoral degree, and the legislation itself specifies those e-passports and IPCs are required.
Can I add something to
I'm sorry, we
clarify?
have one question, one answer, but maybe another member will ask for your clarification. Just like to follow the rules. Delegate Hill, did that answer your question?
Yes, it did. And I'll talk to the sponsor offline. I think they may be able to change the language despite the fact that it's passed in other states. Thank you. Excellent.
Delegate Krebs.
Thank you. And this question is for Mr. Berman as well. Obviously, the Board of Examiners, psychology examiners, are not here to ask these questions to, but they did submit 3 pages of opposition to this, which it was surprising considering you guys made a very good case and have a lot of favorable written statements. But I just wanted you to address one issue they have in here, and I think it's important to address their letter. It is the board that represents everyone. They believe that it actually imposes additional barriers to practice that may restrict movement. And they keep talking about it might be more expensive. And they said because the board is self-funded, licensing fees for Maryland licensed psychologists will have to increase to pay for complaint and disciplinary processes related to out-of-state psychologists. And they'll have to impose a fee on the out-of-state psychologists on top of the fees discussed below to handle the everyday administrative burden. So can you address that? And is
Yes.
that accurate?
So thank you very much for your question as well. So I'll answer that in several ways. SIPAC has been in existence and accepting psychologists since July 1, 2020. There have been 0 reported complaints. In addition, Maryland has accepted 90, and this is information from the Board of Examiners, 90 temporary licenses that have allowed psychologists from other states to practice into Maryland. There have been 0 reported complaints. So in terms of the increased administrative burden, while there have been no complaints that we are aware of. In addition, I know that the financial note that accompanies the bill states that they believe that the budget allows for any increased costs that may occur. And so there's no evidence that we have that suggests there will be increased costs. We go to the nursing compact, which is the longest existing compact that we're aware of. And when I spoke with the executive director, they report there have been no increased complaints as a result of their compact. So it's hard for me to explain the concern in that regard. And I apologize, I forgot the first part. Oh, administrative burden. So here's the way I would answer it if I may. In order, nuts and bolts, in order for me to apply to SIPAC to practice via telehealth, the initial fee is $400. After the first year, there is a $100 yearly fee. And that would then allow me to practice into other SIPAC states, including DC, Virginia, Pennsylvania, and Delaware in the mid-Atlantic region where my patients are located. If I wanted to practice into those jurisdictions and there was no SIPAC, I have to be licensed in those states. Typically, licenses are issued every 2 years. It's about $400 to $500 per state per year. Just in this jurisdiction, it would cost me $1,500 to $1,600 plus per year. So when you compare that to $100 per year to participate in SIPAC, it makes no sense that there is concern about increased financial burden on psychologists, because the numbers just don't bear that out.
Thank you for doing your homework and being very knowledgeable about this. Thank you.
Thank you for your question.
Delegate Kerr.
Thank you, Madam Chair. Dr. Savage, would you care to comment on Dr. Berman's previous response?
Yeah, I believe he was responding to Delegate Hill. And I think one of the questions that she asked was, why was the doctoral degree not written into the original legislation? The thinking behind that, and I've watched a lot of the hearing today, is we've got a massive problem with a lack of mental health providers across this country and in the state of Maryland. Their thinking is if at some point down the road, states or laws or states change their position on allowing different types of providers like master's level, or like in the state of Maryland, we have master's level providers that are called psychological associates who practice under our supervision and our licenses, to be able to broaden the provision of service to access the need, that it's much easier to change a regulation inside the commission than it is to go to 30 states and have them all have to go back and change the law in every state to be in compliance.
Thank you for that. That's an important piece of information I think we were missing. And thank you, Madam Chair.
Thank you, Delegate Kerr. I don't see any more questions from the committee. While they raise their hands if they have any more, I did have a question for Dr. Alvord. I noted in your testimony, you gave one sentence to sort of the situation of children who maybe have co-parents living across state lines and how being part of SIPAC might help them. Could you expand on that a little bit?
Well, several times, we have some children who we are working with, we're working with the families, and then the families separate. And for an example, one child may split the physical custody. So 1 week they're at one house in DC, for example, near our Chevy Chase office, the other week in Maryland. And we cannot cross. Now, during COVID, we've been allowed continuity of care, but that will end. So unless we all are licensed in DC, we can then not see that child the week that they are with the other parent. And we can't also then talk with the parent if they are working in DC and can't get into Maryland. We've actually had some people drive pre-COVID, because we've been doing telehealth for so many years, where they would drive to the Maryland line and sit in their cars and do treatment. It's untenable. And with childcare and with teens, we're hearing about the mental health crisis. It's systemic. So we need to be able to have all parts of the family involved to support the kids. And when we can't cross a jurisdiction or into VA, into Virginia, some kids actually go to school maybe in DC. They live in Maryland and a parent lives in Virginia. We're all pretty mobile and we're all close in this area. We need to be able to have that continuity seamlessly.
Thank you very much. I don't see any further questions for the proponents on this bill, so we will move on to the unfavorable, which I thought would be Lorraine Smith, but evidently is Candace Robinson today. Candace, are you here?
I am here.
Excellent.
Hi. Thank you, Madam Chair and committee. Lorraine had a sudden death in her family, and as the legislative liaison to the smaller boards, I was asked to testify on her behalf. So I apologize. I am basically reading her testimony, and it is in opposition. It states that the board agrees that expanding access to mental health services for Maryland's residents is extremely important, and the ongoing pandemic has shown how essential telehealth services can be. In 2017, the General Assembly passed legislation that allowed for the delivery of teletherapy services, and the board promulgated regulations outlining telehealth protocols and included a provision for registered psychology associates to provide telehealth services to Maryland residents with increased access to care. In response to the pandemic, the board has expanded its authority pursuant to Maryland Code Annotated Health Occupations Statute 18-301E to allow psychologists licensed in other states to provide temporary services to Maryland residents without a license via telehealth or in person. PsyPACT, established in 2015 by the Association of State and Provincial Psychology Boards, is an interstate compact agreement between states that allows licensees to practice in states where they do not hold a license. Currently, 13 states have enacted legislation for PsyPACT. Although the board supports an increase in access to telepsychology services for Maryland citizens, the board opposes 970 for the specific reasons of requirements for a psychology license being different in each state, and the requirements for a psychology license set forth that do not meet the standards established in Maryland. Because the board is self-funded, licensing fees for Maryland licensed psychologists will have to increase to pay for complaint and disciplinary processes related to out-of-state psychologists. HB 970 and PsyPACT, despite a stated purpose of increasing public access to services, actually impose additional barriers to the practice that may restrict movement. Also, PsyPACT duplicates services that the board currently provides without requiring an e-passport or interjurisdictional practice certificate. The board has fully embraced the expansion of telehealth in Maryland, and the board has a separate application for licensure by mobility, which allows psychologists licensed in other states to obtain a license in Maryland through a significantly expedited process. Finally, the board has a process that allows out-of-state licensees to practice temporarily in Maryland through its temporary exception to practice program, as noted above. For all these reasons, they respectfully requested the committee vote unfavorable for HB 970.
Thank you, Ms. Robinson. We have a question from Delegate Cullison, and anyone else who has a question, raise your hand.
And I don't know if I will be able to answer your questions because this is not my board and not my compact. And so they can be relayed to Lorraine Smith.
Wonderful. And just so you know, if you can pass on to Lorraine, certainly we're sorry for her loss, and the subcommittee will be taking this up next week. So we hope we can get answers at that point. Delegate Cullison.
Thank you, Madam Chair. And again, I would pass along my condolences to Ms. Smith. And I'm sorry that Dr. Bishop couldn't be here today either, because I think he might have shed some light on this as well. Because I just want this into the record of the hearing. I understand that you may not be able to respond to it. But I have to say I am extremely puzzled because I sat here and listened to the testimony of Ms. Smith and Dr. Bishop on HB 732, which would have extended telehealth to out-of-state healthcare practitioners, including psychologists. Of a bill that does not have the guardrails that the compact does, that does not require the same kinds of certification necessarily. Now, they recommended an amendment that said that the requirements would be substantially equivalent. The compact is saying it is equivalent. So I am, totally puzzled. The whole idea and concept of administrative burden on the board is, in my mind, increased dramatically by licensing out of state without the guardrails of the compact. So I know that you probably can't respond to this, but it is very puzzling to me that they are interested in expanding access and have come in favor of of allowing folks who are out of state to just come into Maryland by request, at their request, and simply have to show that their certification requirements are substantially equivalent. So given that, I don't know if you want to try to respond, Ms. Robinson, or if we will have to get that response from Ms. Smith and Dr. Bishop.
So with all due respect, Delegate Cullison, this obviously is from their board and not from us. And I don't want to, give an answer that is not correct on their behalf. But I appreciate what you are saying, having just been working on a compact ourselves.
Thank you for listening and being
Absolutely.
here.
Thank you.
Thank you. Delegate Krebs has a question.
Yes, thank you. And I appreciate Delegate Cullison's comments as well. But can you, I'll just pass along to the board. First of all, if they would watch the hearing, there's other board members maybe as well that all voted on this opposition. So if someone could be available for our subcommittee meeting next week and ask them please to read the testimony and watch the hearing and come prepared to answer the questions, because I think I'm as perplexed as my colleagues. So just please ask them to be prepared next week at this. Someone should be present, if not the chair. Thank you so much.
You're welcome. Thank you.
And a question from Delegate Kerr.
Thank you, Madam Chair. Ms. Robinson, we really appreciate you pinch hitting today and understand the situation you're in. So you may not be able to answer my question either. But Dr. Berman had mentioned that in the other states where the compact is in place that there's a lack of complaints. And I was wondering, are you aware of any complaints here in Maryland that have taken place during this temporary agreement time?
Our board doesn't issue temporary licenses, so I couldn't answer on behalf of the psychology board. If there have been any, I apologize, Delegate Kerr.
Oh, I completely understand. Thank you.
Thank you.
And as with all the questions, we would really just appreciate if we could get answers by the subcommittee. I think that would be helpful. Delegate Johnson has a question.
Thank you, Madam Chair, and I don't even expect you to answer if you could just pass along the question. They talked about in their written testimony of the financial burden, but on page 6 of the fiscal note, they disagree and say that they don't think they will need to hire another person, and that the $6,000 cap should be absorbed in their budget with no problem, because in 2019, the board has a fund balance of over $800,000. So if you could just pass that question along about if they could bring us some data that substantiates that, we would appreciate that. And thank you.
I sure will. Thank you, Delegate Johnson.
Okay, I'm looking for any more questions. It looks like every member has asked their questions. I'm just double checking to make sure that looks good. Okay, so with that, we have concluded the hearing on House Bill 970, as well as the work before the committee